A very warm evening to all our esteemed faculty members and respected doctors joining us today. It is an absolute pleasure to welcome you all the fifth edition of Manthan series IHA 2026. Hematology Highlight. It's translating emerging evidence into clinical practice. Today webinar brings together distinguished experts to discuss key specific development present at IHA 2026 and their relevance to everyday clinical practice. To formally begin this webinar, it is my pleasure to invite Dr. Sanjay Kamble, sir. Sir, may I request you to kindly invite our program director, Dr. Ave Bhave, sir, to deliver the opening address and set the context for today's scientific discussion. Over to you, sir.
Thank you, Khushi. Always a pleasure to be the part of such programs. These type of CMEs really are very, very motivating and very, we at the end of the program, it's always something new which we have learned from the experts. So before we begin, again, it's my pleasure to welcome all of the faculty members who have joined today with us and also the delegates who have been joining for this scientific event from the various part of the country as well as from out of the country. So Samartha has always believed to provide scientific platform for such activities, and we have been doing this, and we would be doing these type of activities, scientific events, and that really differentiates Samartha as an organization which really values science. So again, it's my absolute pleasure to welcome Dr. Abhay Bhave, sir. Sir has always been very helpful and kind to be associated with such programs with Samartha. So again, it's my pleasure to invite Dr. Abhay Bhave, who is a senior consultant, hematology and BMT at Lilavati Hospital, Research Institute, Mumbai. And sir has always is very much foremost in devising this type of agendas which would be taken up very, very well by the experts and the oncologists and hematologists in the paternity. So, Abhay sir, welcome, and now I hand over to you to take this program ahead and start the meeting. Over to you, sir.
Dr. Kamble, thank you very much for this opportunity. Are all on benign hematology. Our aim is to look at certain aspects. They may not be new, but they throw new light. So some treatments, sometimes we use it in a different aspect and we didn't realize it was there. So some of these abstracts are throwing light on a newer aspect of use of a drug. Sometimes it is throwing some light on how the drugs are working, real world evidence. So these abstracts were picked up from that point of view to help us in our common practice. They are not very deep research topics. They're not very deep biological topics because we want something relevant for clinicians. So with that, I request, is it Dr. Anchika Sharma? She's the first speaker, or?
It's
No,
Dr.
no,
Kishore.
sir. Dr.
Dr. Kishore
Kishore
Kumar.
Kumar.
Yeah. Okay. Kishore, you can get on with your presentation.
Yeah, thank you, sir. I think, Kushi, can I share my slide?
Yes, sir.
Dr.
You can.
Kushi, I suppose the meeting is to be recorded. It's recording
Yes,
is
sir.
not on, I suppose.
Let me check, sir.
Yeah, thank you, Bhavesh, sir. That has been like quite interesting. So you are more like a teacher out here, and you have made us read abstracts on EHA. So first of all, thanks for that, because it's like an ocean of abstracts and a lot of data, especially to scroll through all the major conferences, and we end up kind of learning nothing. So that happens. So this has been quite interesting to at least get into this. And today has been non-malignant. This keeps us senses better, being a hematologist, not always looking into cancer. So my topic that was given for today is on aplastic anemia. The two abstracts we selected from the EHA. For the want of time, I'm kind of getting into it. But still, some basic thing is, I still remember as a DM resident in 2012, Professor Neil Young was touring India and he had a lecture to be given to us. That time, I still remember him saying, punchline, I should say, two diseases for the last 3 decades, nothing happened. One was aplastic and one was AML. So I think a decade pushed now. So, and that time the mice models of L thrombopag he was so interested in that, and he was hyper into, I mean, like optimistic about how things can change in aplastic, because a lot of things have been used, like let it be even drugs like say even cyclophosphamide for sometimes, thinking that it's an uh, gross autoimmune disease, and we end up losing our patients. Not that everybody gets onto a transplant straight away, especially in a country like India. So that way it has been a real game changer for the last decade to look into data on L-thrombopag addition to the ATG cyclosporin backbone. The two abstracts here, one is S178 and the other is S184, and the 184 has already been presented as a, I mean, published as a full.
Recording in progress.
This 184 has been kind of published as a full paper in Blood recently. So I'll be kind of touching upon these two. So aplastic, I was just discussing, yes, transplant is one option, and slowly we are also looking into a lot of alternative donor transplants that really the donor pool has kind of increased, and the age and all those things, though we had a practical cutoff of 40, 45 inherited, etc., etc. But still, we all practically have got an idea that somebody who is fit enough, why not to give a try of transplants, which may give a long-term remission, but it comes with its own risk and TRMs and things like that. The other way around, big difference is ACE therapy, that is ATG cyclosporin L thrombopag. But why I've been showing this severe, very severe, non-severe, etc. here is because one of the papers discusses about moderate aplastic, where there is not much of data on L thrombopag. The other paper is quite interesting. So this is where the what to say, the present day guidelines are, where severe and very severe. Apart from transplant, it is ACE, and non-severe, yes, maybe cyclosporin, and L thrombopag data is quite patchy. And the definition of a relapse refractory is also quite a gray zone area sometimes. And practically, we say to our patients that even up to 6 months, sometimes we do wait for to see some responses. And many times it may be kind of a partial response, patients having some transfusions on and off, but at least getting out of the hospital. So all these things used to be there. So S178 is actually a paper which kind of looks into a single center. It's just a observation kind of last 30 years, 3 decades, which is quite interesting. So they have just looked into patients who received ATG cyclosporin and who are doing well, not doing well, who are actually defining themselves into two cohorts, which was, one was a relapse and the other one was refractory. Simple words, if I want to say, this is quite a long follow-up data, very practical real-world single-center data, and it had only a clinician preference, not like a very randomized trial. So it was very interesting to look into it. The other one, S184, is a kind of a trial, which is a randomized trial, properly done in patients of moderate aplastic, where addition of L-thrombopag earlier lines, how does it impact in the long run? So they, all this, as Abesa said, all this we know we have been doing, but at least kind of reinforcing what actual data says from the West. Short answer for S178, if I want to say, many times if the patient relapses after some time, it looks like they are salvageable, but patients who are really refractory, they are not that greatly salvageable. And responses, even if we obtain in the relapse or refractory, though the response numbers may be here and there, but the durability of responses is a real question, which practically helps us to discuss openly with the patient what we are going to expect if it's going to be a non-transplant setting. And a simple short answer for the second 184 is addition of L-thrombopag early. In a simple numbers, if I want to say, it was really kind of doubling the responses at 6 months compared to just cyclosporin with placebo alone. This is what the two papers are all about, but still we'll just dive into the paper, what it actually says. S178, as I said, it's a single center trial spanning over 30 years of practice. They had 300 patients, nearly equally divided between one group who were relapsed and one group who were refractory. The things were all maintained between the two. Only thing is, being a 30-year data, so naturally the L-thrombopag availability usage was quite patchy. So it's not that everybody has received an ACE therapy. So it's practically what we have been doing a decade back. So looking into it, and one thing was in the second line HSCT, if you consider, at least 1/4 of patients were going in the refractory category, whereas in relapse category, it was less than 10% of patients who underwent a transplant. Because practical thing is, since they are transplant ineligible or whatever the reason, that's the reason they got an ATG based therapy. So it's very tough when they relapse also, how much fit they're going to really get into a transplant is a practical way of looking at it. Less than 10% only went into a transplant in the relapse setting in their data. So this is what they say in patients who in the relapse setting who went on. This is the relapse cohort who went on to have cyclosporin, eltrombopag, and danazol. And the other one is again repeating an ATG based IST. This was both ATGs. Many times is naturally going to be the rabbit, which was kind of after the horse, it was kind of the rabbit that was used. Alemtuzumab, yeah, they did use transiently because it's a long-term data. Maybe practically off late, how much we are using, we are not sure. But looking at it, let it be the oral drugs combination in relapse setting or the ATG-based second IST, the overall response rates were nearly kind of similar, standing around 70%. But one thing to note down here is relapse-free survival, which was kind of at least double when a 5-year relapse-free survival, which was kind of standing at 74% in the eltrombopag or the oral-based therapies compared to the ATG-based therapies. And an event-free survival, whatever it may be, let it be any kind of therapy, practically looking at somebody after 5 years not needing much treatment or who is totally kind of treatment free, hardly we can expect only in 40% of patients. So that is something which is standing out. ORR and EFS, they're kind of nearly there, but relapse free survival or whatever was kind of relatively better in the cyclosporin, EPAG, eltrombopag, and danazol, the oral therapy arm compared to this immediate second ATG. That was quite interesting because we do think why not to give a trial of a second ATG, but maybe the data, practical data is somewhere here. But any therapy, whatever maybe the responses overall, or etc., the durability of responses is only in about 40% of patients. So practically, I'm going to counsel my patients that if you're going to get the disease back, it's possible less than maybe 1/3 of you are going to be, in the sense 1/3 of the times it's possible that you are going to have a durable response by a second level therapy, which may be just an IST ATG or durable response by a second level based therapy, which may be just an refractory cohort was durable response here. As we see, quarter of patients in the refractory cohort, they are pushed into transplants because that was a desperate situation out there. So drugs are not working. Nearly all drugs have been given, but most of them, they were just in the 1/3 category. So whatever you give, let it be oral. Oral therapies was very, very minimal here because they are probably, they're either they're already on, they are being pushed into a transplant. So immediate ATG, repeating the ATG or any other drugs was not giving that great responses. And as I said, relapse disease is more better to talk about a transplant conversation or book your tickets to Kashi or Rameshwaram rather than kind of what to say, like hovering around multiple other options in these settings. So this is what this data is. So one thing I can see here, this is not a randomized trial. So this is not like head-on-head comparisons and all has not been done. This is moreover, who was selected to what is again a treating clinician's decision here. So a gentler one is somebody who has got a relatively better count, who doesn't need an hospitalization. They are all put into the oral therapy group. So whether that was a bias why the oral therapy group was showing a higher, better responses out there, we don't know. But still, this has got a sharp difference what eltrombopag can do and gives us a practical outlook of long-term data. But one thing we have to take into consideration, the supportive care, the salvage therapies, they all, even looking at the way the number of patients would have gone into a transplant today, maybe even a bit more than what had happened 3 decades back. So that way it is a good data to look into, and nothing wrong in kind of trying a stiffer dose of triple therapy or oral therapy in patients who are kind of relapsing. So that's about 178. When I come to 184, this is a proper randomized double-blinded placebo-controlled trial where there are 85 patients who were, theoretically speaking, they were into a non or a moderate aplastic anemia. So here they just compare two things. Just give cyclosporin with a placebo or add proper dose of 150 eltrombopag from day one, like how we do in the regular aplastics. So this was the data at week 24. Quite impressive. It's just like reinventing the wheel only. Yeah, when it is working in severe aplasia, why not give it a try in a moderate aplasia? So the overall response rates were nearly kind of double at 71% in the eltrombopag cyclosporin arm compared to the placebo arm for that matter. So one thing, they didn't look much into the clonal evolution and things like that, but overall whatever has been reported, they were all looking to be kind of similar. But one thing they have said here is transfusion dependent people, and why do you want to even call them into a moderate? I'm not sure. Maybe that's a theoretical way of looking at things. Maybe they needed an ATG or transplant, I don't know. But then actually the transfusion dependent diseases, they were not doing that great compared to, addition of eltrombopag was not making a great deal of subgroup analysis. It didn't show much differences. But yes, naturally, there was a cross trial also. People were not responding, they were pushed into the L-thrombopag arm, later started having some response. Says CE, that is cyclosporin L-thrombopag in response in up to 3/4 of the patient, which is
Colitis में थोड़ा ना help करेगा.
it comes to Yep. So when I was looking
उसको तुम्हारी
at
gut की health
the,
खराब होने से colitis हो जाता है.
somebody can mute Priyanka. Yeah. So
Colitis or gas भी हुए. Colitis is actually not always a colic. It can
Kushi,
be
can you
diffuse,
mute?
it can be colic. Colic usually hollow tubular structure है. Colon is tubular. So that therefore you can have it, but chronic inflammation যদি ହେଇକି ରହିବ ना, so you can have colic plus.
from that, yeah, thank you. So I can understand colon is tubular there. So I think she's teaching her daughter, I suppose. So one thing that was interesting for me to see here was recent data from Dr. Ramanan. So now we are using ACE. So and say somebody goes refractory, continuing 4 months, 6 months relapse, and the remission rate seems to be not that great. Patient is still like quite nagging us. These two data which are presented in 2025 from Lin and Dr. Ramanan, they're looking at high dose romiplastin as an alternative, I should say, in these kind of refractory cases. I don't know, quite impressive that they are reporting some responses, ORR responses in up to 3/4 of patients. And maybe this is also something to look at, which these two data have been touched upon. So in this discussion, what I can be saying is in relapsed, according to the studies in relapsed SAE, I mean, severe aplasia, oral second line therapy is quite reasonable with patients who have got a preserved counts. But naturally, practical way of looking at an event-free survival is not more than 40% of the patients at 5 years. In refractory, better it is a channel to convert to a transplant or, repeat. Any of these drugs have not been doing that great, not more than a quarter of patients pushing to have some kind of a response. In moderate, yes, cyclosporin erythropoietin upfront looks like it can double the responses at 24 weeks. So better, why not to start early rather than adding it later, thinking that cyclosporin on its own is not working. And here also there is a subgroup which may need a bit more push with ATG, I suppose, which is a transplant dependent moderate, which for all practical reasons may fall into the severe aplastic anemia category. So that's my two paper presentations. Thank you, Ave sir, for the opportunity.
That was excellent, Kishore. Thank you very much. So the premise of this paper, the first paper, was that about 10 to 20% of patients who have received cyclosporin, I made some notes, cyclosporin ATG, with or without L-thrombopag, because like you very rightly said, that time L-thrombopag was not available for everybody. So 10 to 20% will be refractory and about 30 to 40% will have a relapse. And it is these patients who will need some form of treatment. They looked at this two class of patients who have taken the treatment and then either had a relapse or a refractory state. And there were 296 patients, like you said, of which 46 and 150, 146 were relapsed and 150 were refractory. What is very interesting is like you told me that if they have relapsed, that means they had shown a response and then the disease has come back. They do better with whatever else you're going to give.
Yes.
But those who have not shown any response and they have remained low, needing transfusion, they're refractory, they're not going to do as well. So their survival is not as good.
True.
I think that's very important point we've learned from your discussion. And look at the response rates. I mean, if you gave the relapsed patients cyclosporin, L-thrombopag, and danazol, the three oral drugs, after having relapsed from their first ATG therapy, then the overall response is 67% with a overall survival of 91%. So it means that after you've taken one ATG and if you have relapsed, you can still salvage that patient to a large extent by oral therapy, a triplet oral therapy. And I think this paper reiterated our stand. Many of us are doing that because giving a second ATG is difficult, but it reiterated our thought process that we were doing right. Alemtuzumab we don't have, but they are also doing well. But the overall response rate has been 40% and overall survival has been 81%. So not as good as oral. So that's good to know. If you give a second ATG, the overall response has been 68% and the overall survival has been 76%. So not as good as oral.
True, true,
So
true.
it appears to me from this abstract discussion, beautifully done by you, that going to all oral 3 triplet therapy with full dose of L-Trombopag, irrespective whether you use it initially or not, helps those who have relapsed, not
True.
those who are refractory. So refractory have a very poor response to second line of ATG. So therefore, don't waste your time and money on a second ATG, that is a rabbit ATG, because we have to use first one as horse because of the lymphodepletion and immunosuppression which takes place with the rabbit. So rabbit is used for the second as per current guidelines. But then don't waste your time on refractory. Yes, in the other one, in the relapse one, if there's a significant period of time, which is 6 months plus, you could still use the rabbit one and you still have a 30 to 40% chance of salvaging your patient from that and getting a benefit again. The second paper, I think we all are doing that, but it was nice to know we are doing the right thing. That for moderate, we are not using ATG. We are using the combination of two drugs, and that seems to be doing very well. And interestingly, what you told me, the depth of response keeps increasing.
Yes.
So if you were to do CSA alone, it's not good enough. You need CSA needs to partner L-Trombopag.
True, sir.
Or L-Trombopag needs to partner CSA in order to get the benefit. And the overall response rate was 48% at 12 weeks. At 24 weeks, it went up to 71%. And at week 72, it was 75%.
Yes.
So I think you have to just bide your time and continue for a period of time. Don't give up too early, is what the answer I've got in moderately severe aplastic anemia. So Kishore, that was outstanding. Very nice. Thank you very much for your discussion. And I think we can go on to the next one.
Thank you, sir.
Thank you, Dr. Kishore sir, for the informative presentation, for sharing valuable insight into the evolving management of aplastic anemia. Proceeding further, we have our next session with cellular therapy and transplantation, managing post-CAR T cytopenias and optimizing donor selection in beta thalassemia. For this presentation, I invite Dr. Vikash Goel sir from Raipur. Sir, over to you.
Hi, Vikas. Thank you for joining in.
Thank you, sir. Thank you. Thank you, Dr. Khushi. And I am thankful to Samarth Life Sciences for organizing this event and bringing us all together in this platform. I will just start my presentation. Can you see the screen?
No, sir, it is not visible.
Okay.
Sir, if you want, should I share it from
Yes,
here?
yes. Now it's coming, I think.
Okay, yeah.
It's visible?
Yes, sir.
All right. So now I'll be sharing two abstract paper which were presented in EHA 26, topics on cellular therapy and transplantation. And the two topics are managing post-CAR T cytopenias and donor selection in beta thalassemia. So first paper is PF1251. Title is avatrombopag for prolonged cytopenias
slide
after
is-
CAR T cell.
Sir, sorry to interrupt, but slide is not moving. Could you please put it on the full screen?
Okay. Now moving.
No, sir. Could you please share the slide again? It got disappear.
Okay.
It is not visible.
Because do you want, okay.
Now it's,
Yeah,
so I am making it full.
correct.
Yeah.
Yeah, it's
Now
good.
is this okay?
Yes.
Yes, sir.
Moving?
Yes. Yes.
Okay.
Yes.
All right. So the first paper clinical question, can oral TPO receptor stimulation support count recovery after CAR T? And the second paper which I will discuss here is PF1284, matched sibling versus alternative donor HSCT in beta thalassemia measure. Clinical question, how do alternative donors compare when a matched sibling donor is not available? So how the study was conducted? It was a retrospective study. It was done by a Spanish group called GETH-TC study. The topic is efficacy and safety of avatrombopag in the management of prolonged cytopenias following CAR T cell therapy. So as you know, CAR T cell therapy has been revolutionized in the treatment of relapsed refractory hematological malignancies. However, there is prolonged and severe cytopenia, which poses a challenge, and this also increases the risk of life-threatening infection and hemorrhages, while adding a substantial impact on healthcare resources. And presently, we are not having any definitive consensus about the management strategy. So this study was done with the aim to evaluate the clinical impact, safety profile, and hematological recovery outcome of patients experiencing cytopenias after CAR T cell infusion treated with avatrombopag. Orally available non-peptide TPO receptor agonist. And if we compare it with the L-trombopag, it is the study done in healthy volunteers and test or require any dietary restriction when we are using L-trombopag. But here, this is not the case. We can give avatrombopag irrespective of food intake. So total 47 patients were taken in the study, and among 47 patients, 28 were of DLBCL. Adverse events and cytopenias were graded and noted. So the starting dose of 20 mg, and as we know that we can step up the dose or downgrade the dose depending on the clinical response and toxicity. So the median platelet count at the start of therapy was 34,000, with range from 6,000 to 50,000. And the median time to achieve transplant independence initiation was 21 days, and there was no significant difference between whether it is myeloma patient or NHL patient. Side effects included one case of grade 1 persistent nausea and another one grade 1 hepatitis, and which were resolved with the 20 mg dose reduction. Bleeding events occurred in 5 patients, and 4 were, most of them were grade 1. So what they concluded that avatrombopag appears to be an effective and safe therapeutic option for accelerating hematopoietic recovery and reducing transfusion requirements in patients having prolonged cytopenias post-CAR T cell therapy. Our findings suggest that early intervention may be associated with improved clinical outcomes, although larger prospective studies are warranted to confirm these findings. Because they have taken a limited number of cases, like 47 cases only. Maybe in the future, when we have large prospective study, we can confirm these findings. So another paper presented, PF1284, was matched sibling versus alternative donor HSCT in beta thalassemia measure. It is systematic review and meta-analysis. They have included 7 studies having 3,253 patients, and what they have done, they have compared matched sibling donor with the alternative donor approaches, and outcomes included thalassemia-free survival and transplant complications. So as we know that the allogenic HSCT is the only established curative therapy for transfusion-dependent beta thalassemia measure, while matched sibling donors are always preferred, but we know that around 25 to 30% of patients does not have a matched sibling donor. So we look for the alternative donors like matched unrelated donor, mismatched unrelated donor, and mismatched related donors. So individual studies comparing donor types report variable outcomes, and no prior meta-analysis has quantified the comparative efficacy and safety across these donor categories. So this study was aimed to compare the outcome when we take MHD as a donor in compared to non-MHD donor. And in this study, the endpoints were thalassemia-free survival and overall survival, while acute or chronic GVHD and graft failure were the secondary endpoints. So though it is a meta-analysis, they have searched PubMed, Embase, Central, and other the library, scientific library, and they have accumulated the data, and they have compared the outcome, what were our primary endpoint, secondary endpoint, by the statistics. So what they found that they have included 7 studies with 3,253 patients in 6 countries, the time between 2008 to 2024. And in 7 studies, 6 studies were of good quality. And what they found that the thalassemia-free survival was significantly higher when the donor is MHD. Pooled RD plus 8.4%, while overall survival showed a non-significant trend favoring matched sibling donor, RD 3.8%. And in secondary endpoint, what they found that matched unrelated donor had significantly higher acute GVHD, grade 2 to 4, in compared to matched sibling donor. And also the incidence of chronic GVHD was higher when donor is matched unrelated donor. So what they found that the single arm pooled proportion demonstrated a gradient of decreasing thalassemia-free survival. So all in all, best is MHD, followed by matched unrelated donor, followed by matched unrated donor, and mismatched rated donor. So sensitivity analysis excluding potentially overlapping cohorts yielded consistent results, and heterogeneity was 0 across all comparisons. So in this paper, they concluded that this was the first meta-analysis which compared different donor types. And this study confirms that matched sibling donor is superior for superiority for thalassemia-free survival with an 8.4 percentage point advantage over matched donor. And it was driven primarily by the higher GVHD rates with alternate donors. The consistent donor type gradient is MHD, MUD, MMUD, and MMRD. So this provides the quantitative evidence whenever we choose the donor. So despite improving matched anti-donor outcomes, these findings support prioritizing MHD when available and highlight the need for enhanced GVHD prophylaxis strategies in alternative donor transplants. So what the abstract reports, MHD retained 8.4 percentage advantage when MHD is the donor. Alternative donor remains clinically relevant when no matched sibling exists. Outcome depends on donor type, platform, era, and center expertise. And meta-analysis heterogeneity limits one size fits all conclusions. So what should change in the discussion? Both abstract address recovery after advanced cellular treatment. Post-CAR T care focuses on restoring counts safely, while transplant planning focuses on maximizing durable cure. Patient selection, timing, and center experience remains decisive in both the settings. Thank you.
Thank you very much. That was a very nice presentation. So can I just introduce and check with Dr. Khushi whether our panelists are here? We've got a rich panel with us. So Dr. Khushi, can you just introduce the panelists who are there?
Yeah, sure,
Join.
sir. Dr. Bilali Kaji ma'am is there.
Right. Okay.
Also, Dr. Kunal sir is there.
Okay. Has Dr. Ria joined?
Let me check, sir. Not yet, sir.
I can see Amit there.
Yeah, Amit sir is there, right?
And
Aditi ma'am is also there, sir.
Okay, so I'll request the panelists to have their thoughts in the panel discussion. We are going to discuss all these articles in the panel discussion. So what we'll do then is, since they have joined, most of them have joined, we will continue
sir.
with the presentations. And why
Yeah.
don't we take all the discussion about the papers at the end? Is that okay? So we'll do
Yes,
it
sir.
at the end so that the panelists can get a chance to express their thought process. But
Yes,
because
sir.
beautiful presentation, thank you very much. Points were noted. So, Dr. Khushi, we go on to the next one.
Yeah, sure, sir. So thank you, Dr. Vikash Goel, sir, for the insightful presentation and highlighting important consideration in cellular therapy and transplantations. Moving ahead, our next topic is evolving disease modifying in hemoglobin long-term hydroxyurea safety evidence. Now I invite Dr. Srinivas Vijay, sir, from Bangalore to share his expert insight. Over to you, sir.
Yeah, thank you everyone. Thanks Samarth Pharma and Dr. Abhay sir. Thank you for giving this opportunity. So shall I share my slides?
Yes, please, sir.
Yeah.
Sir, could you please put it on the full screen?
Yeah.
Yeah, done, sir.
Yeah, so this is disease modifying strategies in hemoglobinopathies. So two studies are there, PF 1260 and PF 1281. So PF 1260 is about hydroxyurea, whether exposure in especially in sickle disease, what we usually we give, whether it has a cumulative evidence for leukemic or any genomic signal. So that is what they have studied. And PF 1281 is a metapivot in non-transfusion dependent thalassemia with baseline hemoglobin of more than 9.5 gram per deciliter. So here the clinical question was, can patients with relatively higher baseline hemoglobin still gain clinically meaningful benefit? So these are the two studies I am going to touch upon. So the first study, which is the PF 1260. So this is in patients with sickle cell disease with 2 decades of hydroxyurea exposure in a sickle cell disease. So 15 adults with sickle cell disease aged over 50 years were taken, and 11 had at least 20 years of hydroxy exposure was there. And they have done integrated marrow morphology, cytogenetics, and genomic study, and explorative cohort designed to identify long-term safety signals were studied. So the question was, does a very long exposure produce a cumulative leukemic or genomic signal? So there were marrow dysplasia or ATPI in 8 of 11 long exposure patients, especially in 73% of the patients. So two myeloid transformations were reported, and now no consistent duration dependent genomic instability pattern were emerged, and a small cohort and disease related clonal susceptibility limit causal inference. So this author says that this has to be interpreted with, this result has to be interpreted with the abstract study design and stated limitations. So we cannot conclude that this hydroxyurea for long term, if we give, definitely is going to have a marrow dysplasia, but it may be related to other genomic related transformation also. So we have to interpret this result in a given the clinical situation. So coming on to the PF 1281 study. So this is metavate in non-transfusion dependent thalassemia with a baseline hemoglobin of 9.5 gram per deciliter. Usually, energize T study is when patients is around 6.5, especially in transfusion dependent thalassemia. So whether even at 9.5, this drug, which is a oral pyruvate reductase inhibitor, activator, whether it is really going to be useful in these group of patients. So this is the phase 3 subgroup analysis, and non-transfusion dependent alpha or beta thalassemia with a baseline hemoglobin of 9.5 gram per deciliter, and hemoglobin response and facet fatigue were assessed in this study to decide whether this drug is going to be useful in these group of patients or not. So, hemoglobin response was there in 38.9% of the patients with mitapivat versus 0% in the placebo group. And there is the scale also, fatigue improvement was also there in the scale with 5.1 versus 0.8 points with the placebo. And the benefit was detectable despite relatively higher baseline hemoglobin. So the question was, we know that 6.5 definitely the drug is going to we have some benefit, same around 38 to 40% of the benefit. Whether at 9.5% also this drug is going to work. So that is what they have found, that 40% of the patients with this drug have benefited compared to 0% with the placebo group. So subgroup size limit the precision and broad generalization. So that is what the subgroup. So hemoglobin response in the subgroup is, we can see 38.9 months, and they have cautioned that read with care. So hydroxyurea remains foundational in sickle cell disease, and long-term surveillance should distinguish treatment effect from underlying disease biology. And mitapivat targets red cell metabolism and may improve both hemoglobin and fatigue in non-transfusion dependent thalassemia. And disease modification should be judged by safety, laboratory response, and patient reported benefit together. I think very short presentation. Thanks. Any questions we can take up in our panel discussion.
Yeah, Dr. Srinivas, thank you very much. Please wait back, because I think we'll bring it up with the panelists at the end. They've heard your discussion. So, Dr. Kushi, you will go.
Yes, sir. Thank you, Dr. Srinivasa, for the comprehensive and highly informative presentations. Immune hematologic anemia. Our next title is Advancing the Understanding of Immune Hematologic Anemia, Clinical Outcomes and Molecular Insight. It is my pleasure to invite Dr. Priyanka Samal ma'am from Bhubaneswar to deliver the presentation. Over to you, ma'am.
Thank you, Dr. Khushi, but I'll be very obliged if you can share the slides from your end.
Yeah, sure, ma'am. Just allow me one moment.
Yeah, good evening, Dr. Abhay Bhave sir, and thank you, Team Samarth, for the for sharing these abstracts and having us here tonight. And so my topic will be on understanding immune hemolytic anemias. I think a very important aspect while we are dealing with benign hematology as well as transplant, where we find a lot of PRCS and the immune mediated hemolysis. So next slide. So we'll be discussing about two abstracts, and the first one is this is a real world, actually from Asian cohort. They have taken 597 patients who have had autoimmune hemolytic anemia, and the question was regarding what is the phenotype, treatment, and the long-term outcomes connected with the routine care. That is what we practice in our day-to-day life, and what something new which has been done also they have mentioned about that. The second abstract is regarding the molecular characterization of cold agglutinin disease, which is like a different and a separate entity, and most of the time related to the B cell neoplasms, where we need to do whether we need to do something extra at this time point when we have all the tests available with us. That is what they have emphasized on. So the clinical question in that abstract is, can deeper molecular testing reveal biology beyond a routinely detectable B cell clone? So next slide. So when we are discussing regarding the first one, that is the background and the aims and objective, this was the autoimmune hemolytic anemia, the acquired form, which is quite a heterogeneous group of presentation is there. So this is the largest retrospective study in Asia, as I mentioned, and it has been done by the Chinese group. So this aims to characterize the clinical features, treatment patterns, response rates, as well as the long-term outcomes across the major subtypes, that is warm, mixed, as well as the cold they have taken, thereby providing the benchmark for risk stratification and whether we have some novel therapies in treating these refractory cases they have mentioned. So next slide. This is actually the groups they have made into. The L1 is therapy, first line therapy, and here you can see that mostly it is GC is the glucocorticoids. Line 2, at least they have been exposed to two groups, that is rituximab as well as cyclosporin and androgens. Then we have this line 3 where they have used also the cyclophosphamide along with the low dose and high dose of rituximab along with azacitidine and sirolimus. And the line 4 where they have used MMF and exhausted all of them, and some of them over here have been exposed to CAR-T, bortezomib, as well as fludarabine. And this is if we understand, fludarabine is a drug which can cause AIHA, but at the same time, it can also be used to treat relapsed refractory AIHA. 5 lines of therapy, here they have used CAR-T as well. And then there is also a subgroup where it is 5-6 lines refractory, and patients have been given a chance to be treated with CAR-T. Next slide, please. Yeah, so here they have tried to look into the OS or the survival in the patients who have undergone these therapies. So 1 year survival, 3 year survival, and the 5 year survival. You can very well see that the survival curves have increased when they have been treated with the subsequent line of therapies, in spite of the fact that they have remained relapse refractory at 2-3 drugs when they were exposed to. And a significant proportion of the patients have also had a good amount of response with the CAR-T therapy. Next slide, please. I think you have taken out another slide. But what I intended to say over here in the previous abstract, in spite of the fact that these patients were exposed to 4 to 5 line of therapy, there was 5 patients were exposed to CAR-T, and out of that 4 had actually had a complete response and a durable response following CAR-T therapy in this subgroup of patients, that is relapsed refractory autoimmune hemolytic anemia. So that was one of the new things which was added in this abstract, and I wanted to highlight that. So we can go to the next abstract. Yeah. So this was regarding the cold agglutinin disease, which is defined as a clonal disorder where the B cell clones are usually difficult to characterize by the immunophenotypes, which we with the normal ways where we approach a cold agglutinin disease is many a times not very well which we do. So in addition, the frequency of coexisting age-related clonal hematopoiesis, that is like CHIP and all, in cat remains unknown. So the aim of the study was by combining the gene mutations, both the lymphoid as well as the myeloid genes and the immunoglobulin gene rearrangement analysis of the heavy and light chains in the cold agglutinin disease patient samples, they have tried to look into the disease molecular pathogenesis. Next slide. So it was a multi-center, real-life cohort, patients affected with CAD, looking into the clinical and lab data. The genomic DNA from the marrow as well as the peripheral blood was analyzed by the CAP sequence, and they targeted 146 lymphoid and the myeloid genes together. So along with that, the heavy and light immunoglobulin gene rearrangements were evaluated using the amplicon-based NGS approach. Next slide. Yeah, so here they have actually looked into, there are two groups, the AIHA and the one with the PRCA. These PRCAs, among that, the median age was 59 years and 61 years, almost the same. Males and the females were approximately, the percentage was almost 50-50%. You can see the PRCA around 100% of the patients were male, the 3 patients which they have considered. The number of previous lineages in AIHA, it was 4. In PRCA, at least 7. The median was 7. Secondary cytopenias in AIHA, 3 patients had associated thrombocytopenia as well as leukopenia. Hemoglobin was around, the mean was around 7.2 gram per DL. And they have looked into the overall response rate. Here you can see in AIHA it is 62%, whereas in PRCA it has been 87 to 90%. And 24-week CR was 37% in the AIHA group, whereas it was much, much better in the PRCA group. Next slide, please. So, yeah, I needed to mention that the patients who were refractory to 2 or 3 lines of therapy, they were exposed to daratumumab in this group of in this cohort of the patient. So, the question in the first abstract was, how are AIHA? I'm sorry, I think you have repeated. Yeah, how do the two abstracts complement each other? So we looked into AIHF, the first abstract, where they have pulled together the warm, the cold, as well as the mixed AIHA. Whereas in the second abstract, they have looked into only the cold agglutinin disease and how the pathogenesis actually differs. And as I mentioned, in the cold agglutinin disease, they not only looked into the lymphoid gene panels, they also looked into the myeloid gene panels, where they found that clonal hematopoiesis among the myeloid genes was also relevant in this subgroup of the patients. And the treatment with daratumumab, it was a better response with the PRCA group as compared to the AIHA group. Next slide, please. So, what should change in the discussion? Real world outcomes show what patients experience. Molecular profiling explains why phenotypes differ. Some patients respond, some patients do not respond to the conventional treatment. Cats should not be treated as biologically uniform entities, and in real world also we do not consider them as uniform entities. Future care may combine phenotype, clonal detection, and molecular features to guide the therapy. Yes, the clones in the, especially in the cat, if we know the clones, it is easier to target the clones rather than have a broad coverage of just what we add on as like bendamustine rituximab or a bortezomib or just B cell clone directed therapy. Next slide. I think we are almost the end of it. No, this is a repetition. Next slide. Yeah, we got it all.
Hello.
Yeah, thank you. I think we completed all the slides. That was a yeah.
Yeah. Thank you, Dr. Priyanka ma'am, for the excellent presentation and for sharing valuable and clinical molecular insight into the immune hematologic anemias. Now we will proceed further for target therapies for refractory immune medicated cytopenias, evidence with daratumumab and rituximab. For the session, I invite Dr. Deva Dulal Biswal, sir, from Raipur. Over to you, sir. So, will you share your slide? Or do you want us to share?
Hello.
So, am I audible?
Hello.
Hello, Deva sir, am I audible to you?
Yeah. So I am stuck in a traffic. I am just about to reach.
Okay, so should I share
No.
your screen?
Yeah, please share.
Okay, just allow me one moment. Yes, sir, it has been shared.
Yeah. So this topic is regarding um, autoimmune cytopenias. And two important cytopenias here we're discussing. One is anemia, where there is a persistent and chronic low hemoglobin in spite of, means it is almost transfusion dependent. And another is immune thrombocytopenia. Next slide, please. So the first one is PF1295, where daratumab was used in a refractory immune-mediated anemias. And the second one was S315, long-term rilzabrutinib in persistent or chronic ITP setup. So the clinical questions were, can plasma cell targeting? So these plasma cells are parents of antibodies, autoantibodies, and these autoantibodies creating the persistent they are targeting RBCs and creating a persistent and transfusion depending autoimmune anemias of any sort of hemolytic or cold and agglutinin or one antibodies. And if we target, you all know that daratumab can target CD38 tagged cells, thereby they can destroy the plasma cells. And if the plasma cells are destroyed, then these autoantibodies will not be produced, and the anemia can be, means the anemia can be rescued or escaped. So that was the and the rilzabrutinib is there is a pathway in autoimmune platelet destruction. There is a pathway that is BTK inhibition pathway. If that can be targeted by any path, then this thrombocytopenia can also be escaped. Next slide, please. So how the study was conducted? Daratumab study was actually real-world multi-center experience, refractory autoimmune hemolytic anemia, anti-CD34 targeted by daratumab, observational study. Please note it that this is a observational study. And it is a hypothesis creating thing. It is not a means recommendation right now. And next slide, please. What the abstract presented is biological rationale is there, depletion of long-lived autoantibodies, autoantibody producing plasma cells. The abstract contributes multi-center real-world experience. If-level rescue decisions require careful benefit risk assessments. Exact response and safety rates should be taken from official poster. Next, interpret the result with the abstracts, study design and stated limitations. So there is limitation. This is a hypothesis creating, and there is a biological rationale that if we destroy the plasma cell by giving anti-CD38, that is a daratumab. Next slide. But this S315 is a phase 3 Luna 3 trial, long-term extension. This is long-term extension. The study name is phase 3 Luna 3, and 69 adults entered the extension, 52 completed. Rilzabrutinib is 400 mg twice daily. Platelet response, bleeding, fatigue, concomitant therapy, and safety were assured. Are platelet responses and tolerability sustained during extended BTK inhibition was the clinical question that was answered by this phase 3 clinical trial. Next slide, please.
Hello, sir. Hello, Dr. Deva, sir. Sir, you are not audible.
Kushi, can you go to the previous slide?
Yes, sir.
Okay, so I think Dr. Deva Biswal is probably, he was driving, so maybe he's in a no network area. So here in the abstract, you're seeing that on the rilzabrutinib, which is a BTK inhibitor, 59% achieved complete response, and the median platelet count remained between 83 and 139 in the first 2 years, which is an excellent response for patients who are chronic ITPs. No deaths were reported, and one grade 3 adverse event was there, which was with the event resolved without much of a change in the dose. So platelet responses maintained for up to a mean of 80% in the extension weeks. So this looks like a great drug to have for chronic ITP. We already had a discussion on avatrombopag, and now we've got on rilzabrutinib.
Sir, हाँ sir.
Yeah,
Sir,
please go ahead,
sorry.
Dr. Biswal.
Extend
Please.
the slide. हाँ. So that was the platelet response is maintained for a mean of 80% of the extension weeks. 59% achieved complete response. Median platelet counts were 83 to 140 per liter. And during the first 2 years, no death, one grade 3 serious adverse events resolved without any dose change. Interpret the result with abstracts, study design, and say. Next slide, please. Long-term outcomes of S133 read and value comes from the specified abstract population across response maintained in 80%, sir. Completed response out of 59 out of 65%, and they maintained for first 2 years. Next slide. So what should change in the discussion? Both strategies target immune mediated beyond non-specific autoimmune suppression. I mean, usually we give for these autoantibodies, we give steroids and immunosuppression, but here it says that that is a broad approach. Here we try to find out the exact cause. That is, in one, we are targeting the plasma cells, and we have a daratumab which can target plasma cells. They have CD38. And the other way is the for the autoimmune, there is a BTK pathway is there. So that can be also targeted. And you all know that daratumab is otherwise used in plasma, this myeloma, and BTK is used in other MCL and CLL. So but patient selection, durability, concomitant treatment, reduction and safety will be required, especially for the first study, where it is an observational study and hypothesis creating. Next slide. This is done, I think. Thank you. Thank you, sir.
Thank you, Dr. Biswal. Despite being in traffic, I hope you were not driving. But
no, sir. My wife was driving, and
okay.
so was
So
not.
please stay back till the end. We want our panelists
I'm
also
there, sir.
to go through it. Thank you very much for the presentation.
Thank you, Dr. Deva Dulal, sir, for the informative presentations and explaining the emerging evidence on targeted therapies. Our final scientific presentation is titled Risk-Based Supportive Care, EHA Update in Hematology. And for this, I would like to invite Dr. Ketan Modak, sir, Nagpur, to deliver the presentation. Over to you, sir.
Hi, Ketan. How are
Hi,
you?
sir. It's wonderful to have you 2 times in a week. That's pleasure, sir.
Too good, too good.
Yes, sir. So
Sir,
please pardon me. I'm just recovering from flu. So I might have some bout of cough. I'll share the slides.
okay.
Yeah, slides are moving.
Sir, yeah, it's visible.
Right. So these are again, as we have seen, multiple abstracts, mostly therapy-based abstracts from EHA. This is more related to the ion dynamics and the side effects or the risk associated with ruxolitinib. So the first abstract is EHA 1715. It goes by the title of ferritin dynamics and burden of iron deficiency in pregnancy. They have basically showed the results of a paired real-world single-center cohort. We all know iron deficiency is a global epidemic. In pregnancy, it should be corrected to avoid adverse maternal-fetal outcomes. And there are current guidelines which are available for screening of iron deficiency in pregnancy. However, majority of them, usually they have already developed iron deficiency anemias. And we have a very good biomarker in form of ferritin available, but I think that is not so very properly used, as this is what the hypothesis they have given. So what they want to do is they want to address the gap in understanding, and they want to define the magnitude of ferritin change and describe the burden of iron deficiency in pregnancy. So this is in March 2024 at ASH. They had a quality improvement initiative, and it was developed to standardize an approach for screening of iron deficiency in pregnancy. They disseminated this education in their various care pathways. And what they did was they did paired ferritin testing along with the two standard hemoglobin assessment. One was in early gestation, that is 8 to 12 weeks. Another was during late gestation, that is 24 to 28 weeks. And the definition of iron deficiency as per them was ferritin less than 50 microgram per liter. So the results which were given in this abstract were the total number of patients which were screened in those 8 months were 3,373. Of them, 33% had ferritin checked in early gestation and 56 had ferritin checked in late gestation. So they did further stratification and took only those who had a paired ferritin testing in both early and late gestation. That amounted to total of 708 pregnancies for evaluation. And from the this box plot, you can see, if you see the red plot, which is early gestation, and the blue one, which is a blue box, which is a late gestation, you can see there is 67% decrease in the median ferritin level from 63 to 21. So there is quite significant decrease which was noticed. Also in this paired cohort, 86% of the pregnancies had iron deficiency by late gestation. So 5 out of 6 ladies eventually had iron deficiency in the end. So they concluded stating that there is significant decrease in ferritin from early to late gestation. They were able to find out the magnitude, which was 67%. And with over 80% of pregnancies having ID, that is iron deficiency, as they approach the delivery, despite giving iron supplementation. So they basically have put forward the need for discussions which are needed around the current guidelines and the recommendations to be given both for screening and treating of iron deficiency in pregnancy. So this was one good abstract from EHA. The second abstract is on ruxolitinib, basically myelofibrosis patients. They tried to identify those myelofibrosis patients who are at high infection risk while on ruxolitinib, and the hidden role of transfusions, iron overload, and inflammatory status in these patients. And why was the study basically thought about? So we all know infections are leading cause of mortality and morbidity in myelofibrosis patient, be it primary or secondary. RBC transfusions, iron overload, and systemic inflammation, reflected by an elevated neutrophil to lymphocyte ratio, are associated with increased infection risk. Their impact has not been evaluated in a cohort homogeneously treated with ruxolitinib. Hence, they wanted to assess the predictors of infection, including the transfusion burden, iron overload, and neutrophil lymphocyte ratio in these patients. So this was a real-world RUX-MF study, and they have done sub-analysis of that, included 968 myelofibrosis patients. The definitions, few definitions they have laid down. One is transfusion dependency, which means more than or equal to 3 RBC units in 12 weeks before ruxolitinib initiation. Transfusion requirement, that is more than or equal to 1 RBC unit in the prior year, not meeting transfusion dependency criteria. The normal neutrophil lymphocyte ratio was found to be less than or equal to 3.53. And iron overload, as we know, was either more than 20 RBCs or ferritin more than 1000, like we do in thalassemia. The competing risk regression was used to assess various predictors given here. So we'll go through the disease characteristics. This was basically the various parameters which they have led forward. Total number of patients, as we saw, 968. Of them, half were primary myelofibrosis and remaining half were secondary myelofibrosis. Many of them were high risk myelofibrosis. You can see almost 1 out of 2 was high risk. And you can again see 3 out of 4 patients had neutrophil lymphocyte ratio more than 3.53, which again is quite significant, it seems. Pre-ruxolitinib infection history. Did any patient give that? Yes, quite a few. A total number of 163 patients, and majority of them had respiratory infections. Following respiratory infection, it was genitourinary infections. Also, few of them gave history of latent tuberculosis also, which was seen in 21.5% patients. Did anyone receive vaccination and prophylaxis in this cohort? Yes, few patients did. Main vaccination which was given relatively uniformly was recombinant VZV vaccination as compared to other vaccines. Infections which occurred during ruxolitinib therapy. So the median duration of this therapy given was 2.5 years, and patient with more than one infection was 1 in 3 patients, like 29%. But most of them, you can see they were grade 1 to 2 infection, that is 62.4%. And overall 28 patients died due to infection as an actual cause of death. Majority of infections, again, you can see, which we all struggle with, that is respiratory infections amounting to 45%. So the results, what they have given is at 5 years of analysis, the cumulative incidence of infection in the transfusion dependent, in the transfusion restricted and non-transfusion restricted cohort was 43.5%, 36.8%, and 29.4%. And when they did subdivisional hazard ratio and p-value was calculated, it was actually found to be significant in them. In multivariate analysis, all the variables remained significant. So what they concluded was the infection risk while on ruxolitinib was driven by prior infection history and by increased inflammatory and transfusion burden, whereas early spleen response was protective. Elevated neutrophil lymphocyte ratio and iron overload independently increased infection risk, emerging as simple surrogate markers of infectious vulnerability. I think this can be adopted in our OPD practice also. I am basically not doing it. These factors may help guide therapeutic choices, including anemia-directed approaches and targeted prophylaxis. Thank you.
Thank you very much, Ketan, for a very clear presentation. So we'll go on to our panel discussion because I think, Dr.
Yes,
Khushi, we have finished up.
Yes, sir. We have finished with all the sessions. Now the panel
Great.
discussion.
So just a correction on this slide, there is no transplant unit in Lilavati Hospital. It's in Raja Hospital and in Gleneagles Hospital where I go. So that is not correct. The Lilavati Hospital does not have yet a transplant unit. So for those who have joined late, maybe you can put on the panelists on the screen, Dr.
Yeah,
Khushi.
sure, sir.
So for those who have joined late, we welcome you to the discussion on EHA updates 2026, where last time we did a discussion on malignancies. This time it is purely non-malignant conditions. And I'm very grateful to all the speakers who have presented beautifully on the abstracts that were selected. And I thank the panelists, and I hope, Dr. Khushi, these panelists are there, or
Yeah, yes, sir. Panelists are there.
everyone's there, right? Okay.
Yes, sir.
Okay, so welcome everybody. So just to let those who join in late or who have not heard everything, there was a presentation on aplastic anemia and moderately severe aplastic anemia. Then there was a presentation on how to handle cytopenias for patients who are on CAR-T. And the same one, it was Vikas's presentation on who should be the ideal donor for a beta thalassemia major patient for a stem cell transplant. Dr. Srinivas told us about two benign conditions, sickle cell anemia and non-transfusion dependent thalassemia. He looked at in sickle cell anemia about hydroxyurea and what is its risk for long-term use. So it was a analysis of long-term use of HU. And for non-transplant dependent thalassemia, it was on a drug called mitapavir. Mitapavir is an oral allosteric activator of pyruvase kinase. So that is a new drug which is available to us. Then Priyanka discussed on two cytopenias, autoimmune hemolytic anemia and cold agglutinin disease, and what was the outcome in such patients, so longitudinally, and whether there was any clonal disease process in them, both lymphoid or myeloid or either. And then we had Dr. Deva, who spoke on two cytopenias. One was on AIHA and the use of daratumumab in it, including for PRHL aplasia. And the second one was in chronic ITP, rilzabrutinib, which is a BTKI inhibitor. And he deliberated on that. And finally, Ketan spoke on two aspects. One is on iron deficiency in pregnancy, highlighting what it does, how iron deficiency develops in pregnancy, and what are the infections that take place on patients who are affected by myelofibrosis taking ruxolitinib. So these were all the abstracts. There are 12 abstracts in total. So once again, thank you very much. And we'll open up the aplastic anemia first one, where I've given my thought processes that it was people who took treatment, patients who took treatment, and then 10 to 20% were refractory, 30 to 40% relapse. And we said that those who had relapsed respond far better to next line of treatment. And I had made a mention that overall survival was 91% for those who took all oral, that is cyclosporin, L-Trombopag, and danazol. So their overall response was 67% and the overall survival was 91%. And those who took ATG the second time around, their response in relapsed was 68% with an overall survival of 76%. So oral does a little bit better than the patients who have taken a second ATG for relapse. However, those who went on to be refractory, their overall survival was lesser. And importantly, they did not respond well to a second IST, while at least the second IST showed a 68% overall response for the relapse cases. So it was important for us to differentiate between relapse and refractory. So I would love to hear my panelists' thoughts, what they felt about, because all of us face patients who are not doing well following an ATG therapy. So I'll open up the forum. So Dr. Chatani, Akshay, or Tasneem, anyone can, if Ria is there, Ria, what's your thought on this aplastic anemia and the follow-up?
No, sir, Ria here.
Hi,
How
Ria.
are you? Yes, hi, sir. Hi. So aplastics, if the age criteria and now even transplants beyond 40 are also happening. So transplant is obviously the best option if we have a fully matched donor. And though really not recommended, but haplotransplants are also doing good. So if that is an option, if the patient is relatively young, then transplant would be good. If not, then triple therapy. The ATG that we had some years back and the ATG that we have now, there is some difference in the response rate. So with ATG, relapse happening is around, I would put it at around 30 to 40%, what I see. And ATG refractory disease, obviously the choice of patient here is very important. ATG should be initiated as early as possible, preferably within the first month of diagnosing the disease. The more we delay the initiation, the worse is the disease. So in the patients who are refractory to ATG, which is, I think in my practice, around 20 to 30% again, these patients do really bad, sir. Rabbit ATG again is very toxic, very myelosuppressive. So like you said, dual therapy and adding a danazol in such patients would help. And sometimes maybe even taking them up, counseling, and then taking them up for a haplo or a transplant again would be a okay option.
I think this paper, I realized that if you're giving triple therapy and they're getting a good overall response and a good overall survival, we can always keep the transplant for a little later, especially if they're not being transfused, because we all know that the more you transfuse, the worse is the outcome of the stem cell transplantation. So if you've got a patient who's transfusion dependent post relapse or refractory status, then it is better that we think of a transplant. Such are the people who should go for transplant.
Right, sir. So one more actual problem that we are facing is the clonal evolution, which is happening, evolving into AML, MDS, AML, PNH. Recently, I just lost a patient a few days back who had who evolved into MDS, and he was DNMT and TP3 positive. So I think
Sometimes hard to pick up those hypoplastic MDSs who look like aplastic.
Yeah.
They're actually MDS. And
Right.
they're not the types to respond well to ATG.
Right, sir.
Although in the guidelines, it is mentioned that if you've got a hypocellular MDS, you could use ATG in such patients.
Right, sir.
They really don't respond as well as those who don't have the underlying MDS.
Right, sir.
Aditi is there. Akshay, any thoughts you all want to give?
So can I?
Good evening.
Tasneem here. Good evening, sir.
Hi,
Sir,
yeah.
so I'll just say a few words. So I'm a medical oncologist. I don't see a lot of benign hemat. Aplastic anemia also, the ones that I see is very patient selected. Otherwise, most of the people who are otherwise transplant eligible, like you said, sir, who are transfusion dependent, I just refer, because it is better if you have to do a transplant eventually, they start off with you rather than
If
later,
they're
because
young.
I'm not a transplant physician.
Yeah.
But elderly aplastics who come will never be transplant eligible, 70 up. Triple therapy is something that I'm doing, and I agree with Dr. Priyanka about the statistics she gave. I think it's something similar. I've not had a lot of experience, but a few cases that I've done, it is something similar.
Fantastic. Yeah, that is good. Akshay, Aditi, you all want to say something?
Sir, good evening, sir.
Hi.
Sir, it is Akshay this side.
Hi.
Sir, good to see you second time this week and learning from you. Sir, again, practically, sir, I don't know. I am counseling almost 100 of the patient of aplastic for triple or ATG. But I think out of those 10% only take ATG in the first line. Now, the question which come into my mind is that how far we can add this ATG if we are not having responses with the two drugs at 6 months or 12 months. So that is the question which I think we need to get the answer from the trials. That we know that earlier you add ATG, we have the good responses, but we always see that maybe some partial response or no responses with two drugs. And lately, sir, I have seen very good responses with adding romiplostim if they do not respond to cyclosporin or eltrombopag. But romiplostim with the doses of as high as 10 mics per kg, they do make sense and they make the patient transfusion independent for most of the times. So these are the two thoughts.
Great points, Akshay. Thank you very much. I think CMC is doing or done a study on romiplostim in aplastic anemia, if I'm not mistaken. So hopefully we'll hear from them. The exact time for using ATG, if they have not used it, as Ria beautifully mentioned, that the earlier the better. But if you can't for whatever reason, when is the right time? I don't think we know, or it will not be possible to know. No one's going to conduct a trial of ATG done 1 month, 3 months, 6 months post-diagnosis.
So real world experiences can add those things.
So I think in the real world, if you are not going to take ATG upfront, then as time goes along, then taking ATG becomes more and more difficult because you spent on the oral medications, you spent on probably infective episodes, you spent on transfusions. So it becomes more and more difficult. So I think it's only those people who are not convinced about the data. They are the ones who are moneyed and may want to take ATG subsequently, but they should be goaded to take it as early as possible. So thank you for those points. Very nice points, Akshay. Aditi, you want to say something?
I think similar points, sir. So in a upfront aplastic, as per the age criteria, even up to 70, I am giving ATG if they are fit. So it's ATG, TPO agonist, and cyclosporin. And up to the age of 40, we try to transplant even maybe up to 50 if they are very fit and they have a fully matched sibling donor. And at the relapsed refractories, they don't do well. So if they are fit and if they have a donor, we would prefer transplant because the second ATG will not help. And a very important point, as you had mentioned, adding dinosaur to CSA TPO agonist in a relapsed or refractory patient they do very well. Some of the patients completely become transfusion independent. So it depends on what is the age of the patient, severity of aplastic anemia, and availability of a donor and fitness.
Okay, great. So for want of time, because we've got just another 30 minutes left and we've got quite a few more. Because aplastic is such an important topic for all of us. That's why I guess we spend so much time on it. Um, we'll go to the one which Vikas presented. And his presentation was on post-CAR T cytopenias, the GET TC study. We'll take the first one. Just to remind everyone who's on the panel that this was a study where on day plus 14, he mentioned in his abstract, on day plus 14, post-CAR T, with patients who have got grade 3 low drop in platelets, he studied 47, the abstract studied 47 patients of different types, DLBCL, MM, and follicular lymphoma. There was one mantle cell. And the avatrombopag was studied. If I'm not mistaken, avatrombopag was studied, and the dose range was starting from 20 to 60 milligrams. 40 was the average dose that was given. 11 patients received 40 milligrams, and 84% of these patients who received avatrombopag from 20 to 60, average 40, 84% recovered. And I thought that was a great number to have. So their platelets, which were around 34,000, went up to as much as above 50,000. The most important thing is that you could avoid transfusion, platelet transfusion in these patients. So they received a drug which could bring up the platelets to keep them safe. Incidentally, the abstract also mentions that there was a positive effect not only on the platelets but also on the white cells and the hemoglobin. So the neutrophils also did go up, albeit with some amount of filgrastim given to them. And so did the hemoglobin go up. So they became transfusion independent in about 21 days after taking, on an average, 5 to 6 bags of packed cell transfusion. But in a matter of 21 days, they were able to maintain a hemoglobin more than 9 and get transfusion independence. So I think the abstract brought out one very important thing, that if you're facing a cytopenia in a person who's received CAR T for whatever reason it might be, doesn't matter, early introduction of avatrombopag will help us to bring up the counts, not only platelets, but also white cells and hemoglobin, so that we may not face problems of cytopenia. So I'll open this abstract to the panelists. So I've got Kunal. So Kunal, you want to say anything on this? Oh, by the way, the other speakers also can comment. I'm happy for you to take your opinions.
Evening, sir.
Hi.
Actually, avatrombopag is a new molecule as it has recently come in India. So there are some advantages of avatrombopag, like there is no liver toxicity, there is no food interactions, there are no food interactions. So
Big advantage.
plus it is getting a trial lineage response on the standard dose as against to L-thrombopag or romiplostim, which will require higher doses. So it's a very positive thing that on standard doses which are using ITP, we are getting in trial lineage responses. So that was my point.
Yeah, I think that is a very important point. And anyone else wants to make a mention about this?
Dr. Bilal here, sir.
Hi, Bilal. How are you?
Fine, sir. Sir, in Indian scenario, I would say it would depend on the type of product we are using. If you're using Immunoact product, that is only single time infusion on day 0. But immunol product, it's a segregating dosing is there. Day 0, 10%, then day 3, you give 30%, day 7, 60%. So what we have experienced in immunol product, the cytopenias, they persist for a longer time. Till day 30, it is very common. And the patients usually they have a platelet count of around 50 to 60,000, but they are not transfusion dependent. Their hemoglobin also lingers between 9. So using TPO agonist as early as day 14 is a bit risky because there is a hypothetical risk of patient developing CRS because of myeloid cytokines. Though rare, but yeah, definitely there is a risk. So I won't use TPO agonist as early as day 14, sir. I would wait till day 30, then I would prefer using this
So
product.
would it be appropriate to say that we would prefer to use avatrombopag when we see significant cytopenia and keep a cutoff, say 30,000, rather than use it rigidly at day plus 14? But then we'll have to do a study to show that feasibility. But as of now in the abstract, this is what they have said. But your point is very well taken. What type of CAR-T that you have used is also very important. And what's the baseline?
And then we need to check the viral reactivation also, if there is any viral reactivation causing cytopenia. So that is also an important point, because viral reactivation.
Let's assume that you've taken care of it, and therefore that's not the answer. And therefore the CAR-T related cytopenia. Yeah, Aditi?
So in fact, I faced a patient who went into severe pancytopenia, grade 4 neutropenia, grade 4 thrombocytopenia with Immunac for 40 days post CAR-T. And one point to note that he was a high disease burden with marrow involvement with partial response to salvage chemo. So these are the patients, and I had discussed with the doctors from TMH also. So these are the group of patients, especially with a high disease burden or a marrow involvement, or in leukemia if the MRD is high or the morphological blast is high, then these patients we can start TPO agonist early, keeping in mind that they also take time to start acting. And the duration of cytopenia, especially neutropenia, increases the risk of morbidity, mortality. But patients who have a low disease burden or a hematox score which is low, those patients we can wait and watch and use it as and when required. I think we can work around, like maybe they can create a study module around this.
I think the idea of using it early was for the reason that you mentioned, Aditi, that it takes a little while for the plasma levels to accumulate enough to cause a significant change on the marrow. Maybe that's why the trial designers had started it early. But if we have to modulate it, we have to do a study and show contrary to that. If there is no other thought on this one, I'll go on to the next paper, which was published, which was discussed by Vikas again. And this was on which should be the donor for beta thalassemia major undergoing a transplant. So should it be a match related or match sibling donor, MSD as it is called, or it should be a match unrelated donor? Who would be the option? And I think a match related donor, I think we see about 25 to 30% of our siblings being matched to each other. They looked at 3,253 patients in this abstract, which was PF1284. And what they found that if you do a matched sibling donor, MRD, MSD, the thalassemia-free survival was better with an overall survival trending for MRD versus MUD. That's what is done. As far as the thalassemia-free survival, everyone was transfusion independent, which was that thought process. A very important point he brought out at the end when he showed the differentials, where he said that MSD is better than MUD, which is better than minor mismatch or a major mismatch in terms of either unrelated or related donors. So if you have to do, it should be MSD. If you have to do, you can do an MUD. But as you move away from MSD towards MUD or mismatches, either sibling or unrelated, one important last line was increase your GVHD prophylaxis in such alternate transplants. So that will prevent the morbidity and mortality of getting those GVHD, which is going to be the biggest fear in these alternative transplants to MSD. I'll open this paper for discussion, this abstract for discussion. So any transplanters who are interested in speaking?
So I agree with this abstract.
It's a very well written one, yeah.
In fact, even apart from a matched sibling donor in NH, when we were posted with pediatrics, very small kids with grandparents who were in 50s or 60s, or uncles or some related family member who we used to get a fully matched HLA type that were also taken as donors, and those kids also did well. But if match-related donor is not available, then the second option would be a matched unrelated donor, because ultimately that's going to give a transfusion-free and a thalassemia-free life to the patient. So matched sibling definitely preferred, but if not available, matched unrelated is also a reasonable second option. And ATG is usually given for matched unrelated donor, so especially for the chronic GVHD. Maybe a little bit higher risk of dropping donor chimerism with the mud, but that's a second reasonable option.
And just for the transplanters here, what's going to be the best age for transplanting a thalassemia major?
Best would be at the earliest, at least like
An
about
age range?
2 to 10 years is a comfortable range, especially when their iron overload is low and the hepatosplenomegaly is not yet developed. So that would be a good age group.
Okay. Has anyone used luspatercept for thalassemia major to reduce the transfusion need and to reduce the iron overload? Has anyone used luspatercept? There's a BELIEVE trial.
I'm doing it, sir.
Yeah, you're using it?
Yeah, I'm using it. I'm part of the BMS trial PPD.
Oh,
So
wonderful.
pediatrics we are
Can
doing.
because you can't tell us details, but just at least the thought process behind it.
So we are seeing good results. In fact, I had a transfusion. She was transfusion independent, but her HB used to be around 7.5. Now she's crossed 11. The ferritin levels have gone down. She's attained MENAC.
Is a thalassemia intermediate, that means.
The trial currently is for thalassemia intermediates, non-transfusion dependent. But these patients had a lot of iron overload. We did the T2 and R 2-star MRI.
Okay.
Documented iron overload, documented delayed menarche, and with luspatercept, we've enrolled 4 patients already. They're doing good, sir. Apart from that, I used it in Manthan major also, adult. So not transfusion independent, but the frequency of transfusions is reduced. The ferritin is less.
That's good enough. That helps both ways. Lesser hospitalization and lesser ferritin rise. Yeah.
May I ask what is the age group in that trial? Because as far as I know, it's not approved in pediatrics, luspatercept.
It is not approved. That is why the trial. Na?
So, what is the age group for that you all have selected?
Cohort. Basically, they have 8 cohorts all across the world, and they are doing it in 4 centers only. Ours is one. So the age group is 12 to 18 currently.
All right.
And in the next year, Jan-Feb, they are looking up to open the 6 to 12 years cohort.
Okay. All right.
Not seen any major side effects. And all the patients, the HB, ferritin, everything has responded nicely.
And the therapy is just
That's
like
good to know.
myelodysplasia, that is 1 milligram.
Once in 3 weeks, sir.
Start with 1 mg per kg and then go to 1.33, 1.75?
1.25. 1 mg, 1.25 can go up to 1.5 mg.
1.5. Okay. Okay. Amit, you want to say something, Amit? Okay. So that any other thought processes in beta thalassemia transplant?
Actually,
Hi, Amit. Yeah. Go ahead, Amit.
yes, it is match sibling donor is always better than the mismatch or mud.
Yeah.
I have seen patient when I have posted in pediatric in Kokila Bin. So in thalassemia, most of patient do not do well.
In which
I have seen
match sibling
haplo
or
and
match unrelated?
mismatch also. The most of match unrelated. The most of patient will on a higher immunosuppression, they will get CME in reactivation and ultimately
That's the
they die.
fear. That's the worry here.
Yeah, and I have seen one patient who has a double transplanted, but later he developed CME reactivation and died. So I will prefer MSD.
That's one of the worry, which is why, transplantation is great, but then the counseling has to be good and your prophylaxis, both infective and GVHD, have to be very good. Okay. Again, for want of,
if patient if properly selected, even a haplo, like we have a pediatric hemat with us, we just did a haplo. the child was 6 years old and he's doing good. The only problem that we had was he landed up with severe HLH, but which was managed. So I think if patient selection is proper, then even haplo can be given a shot.
After a lot of counseling, and
Counseling, yes, sir.
cost also goes up. Okay, we're going to take up Dr. Srinivasan's discussion. He had two papers, one on hydroxyurea and sickle cell anemia to look at leukemic risk, and the second was mitapavit in non-transfusion dependent thalassaemias. So I'll take the first one, sickle cell hydroxyurea. They studied 15 cases of sickle cell who were older in age. They looked at hydroxyurea for those who are taken for more than 20 years and for less than 20 years. They also looked at the bone marrow cellularity of these patients. They found it to be 67%. So they claim that hydroxyurea does not cause hypocellular marrow. But there was dysplasia in the megakaryocytes in almost 2/3 of the patient. And two patients did convert to acute myeloid leukemia. But then they went on to say that maybe they had a chip, those patients had a chip associated driver with familial mutations more likely to cause the change to AML rather than the hydroxyurea. What they said that there was no higher variant trend seen or gene complexity for patients who are on hydroxyurea to become leukemic. There was no consistent signature of gene instability towards transforming to leukemia. And therefore, they said HU was not a direct mutagen, and therefore patients could be kept on hydroxyurea for a longer period of time, provided, of course, they can tolerate. Otherwise, they're prone to getting oral ulceration on the legs, hyperpigmentation on the skin and nails, and they generally feel fatigued and tired. So now this paper is open, hydroxyurea and sickle cell. I think all of us have used it. Any thoughts on it?
Since Ria, yes, sir. Since I'm
Sorry.
practicing in Nagpur, and Nagpur has I can say maybe the highest number of sickle cell patients.
Yeah.
So we've been using hydroxyurea left, right. We've even gone up to 40 milligrams per kilograms. And honestly, sir, I've never seen a single patient with sickle and a malignancy, let alone AML, in my last 10 years in Nagpur. Not a single.
10 years of follow-up you have, and it's been
Not
fantastic. That's great news, Ria. Fantastic.
Not
Thanks for letting us know.
malignancy.
Yeah. So I think that should put anyone who's using hydroxyurea at rest, that use the dose and keep the sickle cell happy, because having those vaso-occlusive crises are going to be far worse than the fear of developing AML in the future.
Right.
Great. Akshay, you also must be having?
Sir, on the contrary, sir, I have recently seen two patients, one with MDS and one with AML. Unfortunately, we lost a sickle cell AML patient day before yesterday.
Oh.
But again, we do not know whether the hydroxyurea was the culprit or something else. So we have sent the
That's what
NGS.
the abstract mentions, that they might have a chip associated driver with a familial mutation, because in one of their patients who had the leukemia, even the brother had the mutation. So it's quite possible that it was familial and it just came to light a little later, and we thought probably it was related to HU. Although in general, HU has been well tolerated for years. So that's good to know. If there is no other comment on this paper, then I'll go on to Dr. Srinivasan's second, and that is the role of mitapavit in non.
Hello, sir.
Yes.
This is Dr. Deva, sir. I was just asking Dr. Akshay, how
Yeah.
many years of exposure to hydroxyurea in those two
in that patient
cases, sir?
who the two
MDS and
patients.
AML, sir. Yes.
So the MDS patient has been transfusion dependent for last 1 year, and he's 56 now. So recently we did the marrow. I started him on azacitidine. So it is multi-lineage dysplasia, and the NGS report is still awaited.
How many
years of exposure
time
to
for
hydroxyurea?
So he has been on hydroxyurea for more than 30 years now.
Oh, boy.
And the other patient which has
AML.
been the AML. So she was around 45-year-old female, and she has been on hydroxyurea for more than 10 years.
So, I mean, I could guess that they could be just clonal evolution over a period of time, may not be related to hydroxyurea. And what are the doses of hydroxyurea in these two patients? Were they large doses? And so, were they dose dependent?
Yeah. So, sir, both the patients recently got in touch with me. So, the dose what they were taking were around 20 mg per kg for most of their time, and not more than that.
So that's not a very high dose. I mean, Priya is a queen. She's using much more.
No, no, sir. I start with 10. I use lower dose actually.
Yeah. No, I know you won't start with 40 straight away. I know
But
you titrate it. I know you're fantastic in practice. Okay, fine. So the second one on Mitapavit, what I opened that paper where it was mentioned that those whose non-transfusion dependent thalassemia hemoglobin was more than 9.5 were taken into this trial. It was called the Energize trial. And Mitapavit, which is an oral allosteric activator of pyruvase kinase, was used. They studied 194 patients. They gave it at 100 milligram twice a day, and this was compared to a placebo. And they evaluated the rise in hemoglobin at about 24 weeks. What they found out that there was at least 1 gram rise at the end of about between 12 and 24 weeks, and the hemoglobin crossed 10 grams. 38% of patients who were on Mitapavit showed 1.5 to 2 grams increase in hemoglobin by about the 24th week. And the most important, the anemia-associated fatigue, which was there in these patients, significantly reduced with the use of Mitapavit. So two issues, rise in hemoglobin and a better sense of well-being for patients. So my first question is, do we actually need it? Hemoglobin 9.5. Our thalassemia minors are 9.510. So will Mitapavit be used for such patients also to bring up the hemoglobin? So it generally brings up the hemoglobin, or it is specific for a non-transplant dependent thalassemia is the question. So I'll open this abstract to our panelists. Any thoughts?
We know what happened with crizanlizumab. There was a huge hue and cry. We used it in some of our patients, but then it was got off the shelf.
This is the sickle cell.
Crizanlizumab in sickle cell.
Yeah,
So
it was withdrawn. Yeah.
it was withdrawn because ultimately it was found that it didn't really score over hydroxyurea. So
but if you've got a drug which is increasing your hemoglobin,
yeah.
I'm just wondering, are non-transfusion dependent thalassemia, that means the thalassemia intermediates who are even taking 1 or 2 transfusions in a year, maybe, how expensive will it be to use Mitapavit? And they've selected only the good risk, 9.5 and above. I mean, they already have, it's not severe hypoxia.
Yes.
So, 9.5 is a good enough hemoglobin to make it go above that. I don't know what was their concept of using 9.5 as the cutoff. So that part I've not understood. So I've questioned here, do we need it? Do we need such a drug for this? Maybe if their study says 7 and then it goes up, these are people who are transfusion dependent, become transfusion independent, it will be worth, because 9.5 anyway will not be giving transfusions. So
Yeah.
any other thoughts on this?
But Etacept could be a better option for these patients rather than.
Yeah, any drug available for such a situation will always be welcome. But the issue is how many will adopt it and how many hematologists will use it is the question.
Right.
Okay, so if there are no more questions on these two topics, which I assume is the case here, then we'll go to Priyanka's discussion. And she had 2 papers. Both were on anemias. One was on autoimmune hemolytic anemia. The other was on cold agglutinin disease. In the autoimmune hemolytic anemia, she discussed that there were 597 patients, of which predominantly almost 450 patients were warm autoimmune hemolytic anemia. About 117 were mixed, and more of them were cold agglutinin, but mixed. 31 were DAT negative. We do have in practice DAT negative hemolytic anemias. And in this, they found that these patients, when they took treatment, it was quite favorable. They did quite well. They did better than everyone else, actually. And the follow-up was for a period of almost 50 plus months. 50 plus weeks, sorry. Those who are warm AIHA, the unfavorable features that are there in warm AIHA, those patients who will not do well are the ones who are older than 60, those who did not respond to corticosteroids, those who developed infections as part of therapy, whose hemoglobin was 6 to begin with and kept lower needing transfusions. And they calculated something called as a bone marrow responsiveness index. Now, they found that the bone marrow responsive index was low. These patients generally did not do well on the standard therapy. And that is calculated by the corrected reticulocyte count divided by the maturation corrected factor. And there is a way of doing this. They also found that IgM or IgM plus IgA had a worse event-free survival at the end of 17 weeks. They had higher incidence of infections and relapses, especially when you're tapering steroids. But what they did say in this abstract that steroids will remain the first line of treatment with more than 90% responding, especially the warm AIHA. Rituximab came second with a response rate of 54%, which is not bad considering that it is, we use it more for ITP than AIHA. Cyclosporin was not very brilliant, 17%. Cyclophosphamide was 4.5%. And mycophenolate, surprisingly, was 3% because the current guidelines do tell us to use MMF much earlier. In fact, MMF can be used upfront because it takes time to work. So it can be used upfront with steroids and rituximab for the severe AIHAs. So there were 2.5% who had undergone splenectomy in these also. So I'll open this paper up for discussion. AIHA outcomes. What do you all see in your...
Sir, any use of daratumumab? Because the
yes,
next
there's
paper
another
is...
paper. We'll come to that, which is also...
No, in this one, the
yes.
choices were rituximab and steroid and those things.
No, this was the one which was studied in this abstract.
So
when we come to the next abstract, we will discuss about DARA and the others.
Sir, no, sir, I was asking that whether any correlation, because the next abstract is on the same topic.
Yes.
Where they have used this one as a choice, as an option.
Yes. So I'm sure those who are refractory patients could benefit from additional therapies. So there is bortezomib, there is daratumumab, there is CAR-T, I've got a girl in one of the hospitals where I go, she's refractory for 4 lines of treatment of AIHA, and she's undergone splenectomy and she still remained refractory. She's round face, round body because of steroids. She's 19 years of age and I gave her simple RCVP. Her hemoglobin as of, I think 7-8 days ago when she came for a therapy, she's finished 5 RCVPs. Her hemoglobin is now 13. She's transfusion independent. She was getting a transfusion almost a week in the last 1 month before coming to us. So RCVP. So, there are various combinations. The issue is as you have to use standard ones which are recommended by guidelines and then move away laterally towards other agents. And we're going to discuss daratumumab as one of them. But in this, your thoughts on AIHA, what do you all see? What do you all do? So I'll start with Amit, if Amit is there, and followed by Kunal.
Yes, in generally in warm AHA, I will start with steroids, and while tapering below 20 milligram, we'll add MMF as because MMF takes around 2 months to act.
Yeah, at
so
least weeks. Yeah, easily.
So
earlier we start the
patient will remains still 2 months. Patient will remains on lower dose of steroid. So generally 70 to 80% response, and on MMF we saw there is almost 70, 50, 60% there is partial response only, more than 8. But generally I don't do anything. Means if it is not maintaining below 8, then I will consider rituximab. And if there is no response to rituximab, then I will consider sirolimus and will other options rather than.
Kunal, any thoughts different?
I usually start with steroids, and after started tapering, I add azathioprine. I have a good experience with azathioprine actually.
Yes. Yes, you not
So
mentioned this abstract. You're right. It's a great drug to use.
so I had good experience with azathioprine, and if the patient is steroid dependent on steroid refractory, then I'm counseling for rituximab.
Right, right. Okay.
And cold AHA upfront, I'm counseling for rituximab in cold AHs.
Okay, so we'll come to that. We'll have a discussion on that. If there is no other thought on this, then uh, can I ask the panelists that when you start the steroid and AIHA, how much is the minimum time you keep 1 mg per kg for such patients? Say, for example, you're using prednisolone. So if you're using that, you'll have a plan or it is patient to patient. What is the minimum amount of 1 mg per kg you will give your patients of AIHA? So Akshay, we'll start with you. Then we'll go to Aditi.
So it is generally 3 weeks of complete 1 mg per kg, and then generally I taper and keep it for at least 6 months on steroids. That is what my practice is. And sir, in this abstract, something was discussed about CAR-T. So probably Priyanka ma'am's patient, the abstract.
Yeah, it was Priyanka.
So
Correct.
yeah, so she had discussed about CAR-T in
6 patients underwent CAR-T, 5 of them responded quite well. This is what she said.
yes. So what was the target for the CAR-T, sir? Matlab, what was it, multi-antigen CAR-T, or it was specific for any CD20? That probably we
It's a
need to know,
great
sir.
question. I looked at the abstract and I was unable to get more details because in that EHA abstract book, only certain amount is available. So I cannot answer your question, but it's a great question. What do you target? Absolutely. Maybe it's good to target B lymphocytes only because they are going to produce the antibody for the autoimmune hemolysis. So it has to be a CD19, CD20 target. It can't be anything else, but they have not
Yes, sir.
mentioned that. They assumed that it is a B cell target. Aditi?
So steroid 1 mg per kg for 3 weeks to look at response. And if patient is responding with at least 1 gram plus rise in HB, then very gradual taper. I take almost 6 to 9 months to gradually taper. And if during taper there is a drop, then add the second line early. Uh, Also, one point I wanted to add is that they were looking at patients, the bone marrow response, that is the low retic count. And there are papers, and also we have also done in patients who have received first line, second line, and still not responding well to the therapy, adding erythropoietin stimulating agents, if erythropoietin level is low,
Yes.
also helps.
Yes.
And in KEM, we were facing a lot of parvovirus infection also. We had a couple of patients of AIHA with additional parvovirus infection. So
Yeah,
giving
so there will be
IVIG
like you'll
did
have a
help.
CLL with AIHA. You'll have such cross, but pure AIHA, I think we're all using standards. So can I just make a comment that it's best to get off the steroids soon, otherwise you will land up in a lot of issues with steroids. So especially if they are not responding very well, I think beyond 6 weeks, maximum 8 weeks, to continue with steroids sometimes puts you at a higher risk of certain infections. For want of time, I'm going to skip the cold agglutinin disease because there sutimlimab has come up in a big way, and that can be now available in our country also. Problem is it has to be taken for a long period of time. It also has cold agglutinin disease can have clonal disease. I think Priyanka brought it out very well that not only lymphoid but even myeloid clones such as TET2 and DNMT3, ASXL1 can be seen in these patients of cold agglutinin disease, and therefore it may be beyond a clone. IGHV is there in everybody. In all cold agglutinin disease, 100% of them have it, IGHV gene mutation. Maybe that will be a target in the future. But can we go to Dr. Debadulal's two abstract? And I'll have to take both the abstracts because both the abstracts were great. DARA in AIHA or PRCA and Zelzabrutinib in ITP. So in the DARA AIHA, there was it was between 2020 to 2025, 16 patients. They all received one rituximab plus 4 DARAs in the minimum. And the overall response rates were 62%. And these were patients who have taken other lines of treatment. So even the pure HL aplasia has responded 87% in 24 weeks. So I think absolutely brilliant for DARA. I've got a patient who's in Siliguri just now who's resistant to 3-4 lines of treatment. And he may be a very good candidate for bortezomib or daratumumab based on this study. So I'll open it for my panelists. The time to next treatment on daratumumab was 1 year for AIHA. That's what the abstract says. I think it's a fantastic drug to use, provided it is affordable.
Yeah.
It's, I think, sir, this is one of a very good treatment for, especially for PRCAs, because a lot of
Yes.
PRCAs don't respond.
PRCA 100%.
Yes, sir.
So they are 100% transfusion independent at the end of 1 year, which is unbelievable for PRCA.
Yes, sir.
Provided they don't have a thymoma. So otherwise, thymoma is the best way to go about it.
Yes, sir.
If there are no comments, because we're really running out of time, if there are no comments on this one, I'll go to rilzabrutinib in chronic ITP, who have at least had, this was the Luna 3, phase 3 Luna 3 trial, 69 patients, 4 prior treatments given, and 1/3 of them have undergone splenectomy, and the average platelet count has been around 18,000 in such patients. And these patients not only had a rise in platelets, but they also had one very important response, like in the hemoglobin, and that was fatigue. Thrombocytopenia causes fatigue, and it was much better. So there was a 99% compliance to rilzabrutinib. It is well tolerated, and the most important thing is this is a non-steroid therapy. I think these are very important factors in rilzabrutinib. So I'll open this abstract to our panelists. Rilzabrutinib in ITP, chronic ITP. I don't think anyone of us used it, but I think
Yes.
great drug to keep it in mind. Yeah, Amit.
It is great. I mean, it is great drug because most of 20 to 30% patients will not respond 2 to 3 lines of treatment. So basically, we'll
You know
see.
what, Amit, I'm just thinking ITPs can survive with platelet count of 20, 30,000.
Yes, yes.
So, as a hematologist, do I have to bring up the platelet count is the question. Or can we get away with an asymptomatic dry ITP who is never bled? If the platelet count is 20, 30,000, 40,000, can we just leave them alone? Today's world does not want that.
Yeah. Actually, we will not treat if platelet is more than 30,000. And
so these are patients whose platelets are dropping constantly. I think they have picked up platelets of somewhere between 5,000 to 30,000, average of 18,000. So I think those who are very low, they are the ones who are the problem. Okay, we'll go to the last abstract now, because I think we have 3 minutes gone beyond time. And this was very important, what Ketan has presented. And that was iron deficiency in pregnancy. It's a big problem. 60 to 70% of our pregnant women, 60 to 70% of our women are iron deficient. Double that number are iron depleted with normal hemoglobin, so IDWA. And on top of that, is such women went into pregnancy. Ketan has brought it out beautifully that there is a 67% chance that you will develop an iron deficiency during pregnancy if you don't react to that iron deficiency. And remember, the new target by American Society of Hematology is 50 as ferritin, not 30 or 15. So 50 is the cutoff in pregnancy. So if you got a woman whose ferritin is less than 50, she is considered iron deficiency in pregnancy, and she should be a candidate for treatment. Earlier the better, in the second trimester itself. Whether it's oral, whether it's IV, it's a different matter. But your aim is that by the time she comes into the mid second trimester, late second trimester, she should be iron replete, because that's the time you're going to give iron through the syncytial trophoblast to the fetus. And therefore, you should be repleting iron by the late second trimester, or definitely by the early third trimester. And then at the time of postpartum, you'll give one more shot of IV, because they do have some blood loss during delivery. And then they don't have to worry about oral iron at home. Most of the women forget at home. So this was important. It is a very important eye-opener. 86% of iron deficiency takes place by late pregnancy in women who don't receive iron. And this is beautiful data, which should make all the skeptics believe that iron is important in pregnancy, so that we can do well. And his last presentation was of infections and myelofibrosis. I guess respiratory infection is the biggest worry in Jakavi or ruxolitinib. I think the paper brought out one important factor. Early introduction of ruxolitinib is important because the spleen reduces, your immune systems get better. So if you have to use ruxolitinib, please use it early, pre-fibrotic phase or early as possible, so that you can get maximum benefit of these patients. And 968 patients were studied in this. So I think that was his paper. I'll now open these two abstracts, anemia in pregnancy and MF with infection, as the last discussion before we hand back to Dr. Kamble, who's very patiently waiting over there and has not yet interrupted me. Thanks.
So
yeah.
I actually have a question to the audience that what antimicrobial prophylaxis is everyone using while on ruxolitinib?
Acyclovir is the most important.
Yes, sir.
Yeah.
So
And
apart from
vaccinate, and vaccinate them. Use the 3 vaccinations.
Yes, sir.
And get on with it. Yeah. Any other? Yeah. Sorry. Go
I've
ahead.
seen one COX reactivation.
Oh yeah. That's a
And-
problem.
Yeah.
That's a problem in our country. I've got 4 of them.
Yes.
And it's very hard. You don't know what to do, whether to reduce ruxolitinib, stop ruxolitinib, continue at an altered dose. It's very hard because there is an interaction between the AKT and this. Okay, so if there's no more question, then I think I'm going to hand it back to Dr. Sanjay Kamble and his group. Thank you, Dr. Khushi. Pawanji, Omji, thank you very much. Dr. Kamble, all yours. Thank you for getting all of us together and this opportunity.
Thank you, sir. That was very informative and very engaging session. You really navigated the things very well, right from the time when the first speaker spoke about the data and then coming to last. You never missed any point. That's the whole beauty of how you conduct the meetings. And of course, the speakers were really very brilliant on their part, wherein they demonstrated that data so well. I hope that most of us and even the delegates might have enjoyed the whole proceedings. Thank you, sir, for being here. So over to Om for your concluding remarks, and then we can call it a day.
My conclusion is always that I'm thankful that Sir gives the time whenever we have requested, and looking forward for more exciting Manthans going ahead, as we have already discussed, sir.
Yes.
So we'll be planning it and we'll be doing it. Thank you so much for giving your valuable time, taking out from your busy schedule, sir.
I think
Thank you, sir.
Dr. Ved has a Manthan, so please tell the audience if they can join Dr. Ved's Manthan also.
Sir, yours is coordination is separate. His coordination is also separate, sir. Thank you, sir.
All the best. Thank you very
Thank you,
much,
sir.
everybody.
Thank you.
Thanks for
Thank
all
you so much,
panelists
sir.
and all speakers. Grateful. Thank you very much.
Thank you. Bye-bye. Good night.
Thank you, sir. Bye. Good night.
Thank you.